Yeah. Last 2 minutes.
Yep.
If any question, any urgent communication.
Okay, I'm gonna go ahead and put us live. Here we go, guys.
Okay, welcome. Good morning, good afternoon, good evening, wherever you are in the world. We're very excited for our second Oracles of Eye Innovation webinar. And I would like to welcome also my co-moderator, Eileen Kilic, as well as Chris Morrow, that helped me putting this program together. And generally, the idea is, we reached out to friends in the ophthalmic sector from various disciplines. And because we're all missing the personal interaction where they usually share their exciting technologies they're working on at a glass of wine or beer, we thought it might be a great idea to have that interaction, sharing this innovations are coming, they're working on a more social level, like what we're doing now with webinars. So it's a great pleasure to have this time, again, a fantastic faculty, pretty much around the globe. We have people now from Canada, Ike in the OR. He is actually transmitting live from his surgery room. We have Damien Gattinel from France, Ashwin from India, Flumena from, I think from Portugal, if I got it right. We have Keith Barton from the UK and Toby Neuer from Germany. So a pretty exciting faculty. And I really personally cannot wait to hear what makes them sleepless in the night and what they cannot wait to get the innovation into their hands. So what are the topics that is driving them, motivating them, and what's coming new in our field of ophthalmology? So I'm very excited. We gave all speakers a little bit of a guidance of what we are like to hear. So first of all, why is that innovation, this technology, this procedure exciting them or exciting me? How does it change potentially the life of a clinician? How does it change the life of a patient? And how does the innovation in particular solve a specific problem? So addressing a kind of really, how does it fit into a day-to-day life of a clinician? Also a little bit of a side constraint we said is, we want to hear new stuff. We don't want to hear technology that's out there for years and there's some minor improvements. We really want to hear what they think is coming in future, what is coming, driving our field forward from a technical perspective, clinical perspective, or maybe a business perspective. And that's pretty exciting to have these speakers that are going to share with us different perspectives, starting from more the anterior part of the cornea, going towards physiological optics, and then moving over to the space of glaucoma. So it's really, really exciting, broad range of applications. And by saying so, I think welcome again. Thank you for the speakers, for the faculty, for joining us. And by that is, so I'm really looking forward. Why does it excite you guys to be involved in this innovation? And by saying so, I'm moving over the moderation to Eileen.
I would like to introduce first speaker. I would like to introduce first speaker.
Okay.
Can you hear me? Tobias Nohan is famous cataract surgeon from Germany. He will talk about special cataract technique protecting endothelium. We are very happy to listen his talk. Thank you so much, Tobias, accepting our invitation.
Okay. Thank you very much for your invitation. So I hope I can make it.
Yep, You're on the screen, Tobias.
Okay, hello. Thank you very much for your invitation. Oops, I'm looking for my presentation. I just had it before and now it's gone. Where is it? Just a minute. Sorry about that delay, but this is that is life.
Yes, yes, no problem.
Now you have it. You can see my presentation.
Yes, we can see at the moment.
Okay. This also, that's the title. So presentation is online.
Yes.
Okay. So what I want to show you is a new technique for protecting the endothelial cells during cataract surgery. And in general is reducing the, just a minute. Reducing the endothelial cells during anterior segment is a ongoing story since many years, and even with modern phaco techniques, endothelial cells can be harmed during phaco. And the femtosecond laser assisted cataract surgery helps us to reduce the endothelial cell loss to a significant way in many cases. We also learned additional viscoelastic techniques, such as the double shell technique from Ashinov, and still from the 70s till today, different groups are working to find a solution like a soft contact lens material to mechanically protect the endothelium cells. And here are some publications of protecting the corneothelial endothelial cells with polymacone. Polymacone is also hydrophilic material, and it didn't work really good for that. And also another material called polaxamer, which worked in porcine or rabbit eye, didn't work as a protecting shield for the corneal endothelial cells in humans. So finally, there is a new application of the femtosecond laser, which offers us a great option. Everybody who is doing cataract surgery with the femtosecond laser assistance knows this picture that the femtosecond laser has already done. And when we start the video, normally we all do and remove the capsulotomy or the capsulorhexis. And this is something you should not do. So bring it back. Why? Because it's a fantastic material. It's clear and it's inert and it's fantastic to use it. So don't throw it away anymore. And the technique here in animation shows you, you do the capsulotomy, then you divide the nucleus. And after that, you go inside underneath the capsulotomy and lift it and press it with the viscoelastic against the endothelium. And so it's the own material of the patient which you are using for protect compromised endothelial cells. So we did a little study which is still ongoing. We have now more than 100 patients. We have eyes with Fuchs disease, and especially in these eyes, you should use that. The other eyes were just to see if this technique will work and if the endothelial cells will really tolerate their own capsulotomy on their cells. And the parameters we were focused on were endothelial cell density and the pachymetry, because cornea will swell a little bit during the surgery. Good. There was a study group with endothelial cell protection and a control group. And the control group was always the second eye of the patient. So we did in one patient when we have planned both eyes. We did the one eye with endothelial cell protection with the capsulotomy on the endothelial cells, and one just standard. We looked in this little study, what I can present now is 1 day, 1 week, and 3 weeks. And if we compare pachymetry and endothelial cell densities, we found not a really statistical significance. In columns, it looks like that. Preoperative, naturally, it's the same. On the first postoperative day and also in the first postoperative week, there was no big difference between the protection and without protection. But after 3 weeks, we had, as good as we could measure the endothelial cells, a much better result for the protection group than without. But you all know it is really, really difficult to measure endothelial cells with the devices we have. So it's not precise enough to really say yes or it works or it works not. The same we had with pachymetry, and also after 3 weeks we saw, let's say, not a statistical significance, but a clinical significance in a much thinner cornea thickness after the surgery than without protection. And here is just a picture. I finished the surgery, and then you just go with BSS on the endothelium, and then you see on the left side the capsulotomy, which is now removed when the lens is already implanted. And especially in patients with Fuchs disease, it's really amazing how the cornea will look at the end of the surgery. It's crystal clear, and especially the days after the surgery, day 1, day 2, and 3 weeks, we all know that the Fuchs disease is really an enemy for cataract surgery, and often takes weeks that they get better and better and better. But with the endothelial cell density with this Fuchs disease, you have the next day a crystal clear cornea. This is really, this was the most amazing thing. And so the clinical significance with this technique is definitely there, but how can I prove? I cannot really count cells in Fuchs disease. It's with the devices we have, it's not possible. So the only thing is what you have is to prove is clinical significance. And the second part of my talk is, this was now used, the capsulotomy from the same patient in his own eye. But you can also use a capsulotomy from patient A in patient B. So here we see the tinted with the blue capsulotomy in BSS. I aspirate this capsulotomy with just a DMEC cannula. It behaves really very, very similar to a DMEC. It's just smaller. The capsulotomy is 6 millimeters. The DMEC is 8 millimeters. And just let me show here, I hope I can do it. What you can see here, it needs a little bit explanation. This is an artificial iris. And in the center of this artificial iris, there is a IOL clipped in. And this patient was done the surgery 5 to 6 years ago and had now a very, very low cell density, and was referred to us that we have to remove that. And I called the company because I didn't know the device, and they told me what it is. And you see here 3 parts is an enclavation on remnants of the iris. And this center is an intraocular lens. And what I did is I implanted from the different patient this tinted capsulotomy, put it on the endothelium, and now in a fast mode, I do the exclavation of this implant. Then I have to remove the center part, which is the IOL. Everything is done underneath the protection of the endothelial cells. Then I have to break these two parts. And now the patient is aphakic, has no lens inside. And now I have to implant a lens. No capsular bag is there. Therefore, I have chosen the Yamane technique, which I really think is very fascinating. So I do the Yamane technique, and all this manipulation with an endothelial cell density lower than 500 per square millimeters is done under the protection of the anterior capsule with the endothelial cells. And the amazing is, next day it's a clear cornea. And we all know that in these delicate surgeries, it's not so easy to keep the cornea clear, even with visco, because I remove it now. It looks like directly at the end of the surgery, and you have a super, super clear cornea. I have a second case. Now we bring it out. In a second case, this is familiar to many of us. This is a phakic anterior chamber lens, Bykov lens, also 380 cells density, very, very delicate. I have to remove this phakic lens because of the low cell density. I do exactly the same. I bring from a different patient the capsulotomy into the anterior chamber, bring it with visco onto the endothelial cells. Then I remove this anterior phakic lens. And now I also have to do a surgery and the next day. And here you can also see here in this part, the shadow of the haptic of this lens. And when you have delicate cases in the anterior chamber or a low endothelial cell density, then I really would propose to use the capsulotomy of a different patient or of the same patient, whatever you want, and it's great. So to answer the magic 5 questions which Michael just introduced is, what problem does the chosen technology solve? It solves that we have that we can protect few healthy remaining corneal endothelial cells in a significant way. And the innovation solved the problem that I'm using really the unique properties of the anterior lens capsule, and therefore please don't put it immediately away, as we all do it every day, and put it in the trash. No, think about that you can use it, and it is fantastic. And how does this innovation change the life of patients? Clinical, much better postoperative results, and the beauty is no additional costs. And this innovation changed the life of the clinicians, because when you do these delicate surgeries, you can sleep much better after adopting this technique, and has a definitive little learning curve. And why does the innovation excite me? I think it's for the first time that we are respecting and using this precious autologous tissue for the help of our patients without additional costs. So thank you very much for your attention.
Thank you so much, Tobias. It's really, really wonderful techniques to protect endothelium, which is very important for us. I will have a very quick 2 questions. One question is, you introduced with femtosecond laser capsular access. Is it possible, do you recommend also with manual capsular access? Is it possible to use when we do capsular access without femtosecond laser? And second question, when there is a protection endothelium, when you remove capsule back end of operation, is there any complication? Sometimes maybe attachment to the endothelium, maybe you need to, maybe some special surgical maneuvers may be needed. Is it easy to take out? Just two quick questions.
Okay. First question, how you create an anterior capsulotomy or a capsulorhexis? It's if you can make it in one piece, then it's good. If it is not one piece or it is unstable, the flap, then it's more difficult. Definitely it works, but it's much more difficult and much more delicate than to attach it. But you can use it also from the septo, but the septo sucks it immediately away, so you have to look where it is. But you can use it, definitely. The same thing is, it's the longest the learning curve is to change your phaco technique so that the aspiration of the phaco during the protection of the capsule is that you don't go in the direction and aspirate it, that it sticks there. At the end of the removal is, you must not touch it. You just go with BSS, you blow a little bit with BSS and it's gone.
Okay.
So to bring it away is super easy. Let's say the most sophisticated thing is to keep it there during whole phacoemulsification and aspiration.
Okay, perfect. So Ashwin, you are doing also amazing surgeries, cataract and cornea surgeries. Do you have any comment and any question?
I think, Tobias, I think this was brilliant. The way that you've shown it and the way that you've described it in detail, it's extremely brilliant. I know till now we've just had viscoat and things like that that kind of protect us, our endothelium in these cases. And it's always an if and but in these cases. Oh, what if that happens? And but should we do this? And a lot of people are also a little bit uncomfortable using viscoat, especially because of the cost that's involved sometimes when it comes to that. And also what happens is viscoat kind of does change, in my cases at least. I'm sure that a lot of people might agree with me. Viscoat doesn't behave the same way as a dispersive would, and so it does change the dynamics, the fluid dynamics of a surgery itself. So having said that, this is a brilliant technique to actually prevent endothelium from actually getting damaged. So thanks a lot, Tobias.
Thank you.
Thank you, Tobias. Again, if there is no question from panelists, I will continue to introduce next speaker. Damian Gatineau will be our next speaker. He is really very innovative in refractive surgery area. We are using a lot of technique from Damian, measurement technique, refractive outcomes. Always we are using his name. Now he will talk about wavefront aberrations, revisiting wavefront aberration for better refraction and visual quality assessments. We are listening you again, Damian. Thank you so much accepting us.
Oh, thank you. Thank you for inviting me. It's a pleasure. And so it's a very nice program, and I hope I will try to convince you that it's time to revisit a bit the wavefront aberration. I would like to thank all the co-authors who are listed on that first slide. I have also a little financial interest, which may be relevant with NIDEC here. And I think that until now, we really did not have what we need in terms of accurate and clinically accurate wavefront measurement and wavefront interpretation. What we should have now today is accurate, realistic, objective refraction prediction from wavefront analysis. And what makes the essence of wavefront analysis is that you can have, through higher order aberration decomposition, an accurate, realistic metric or set of coefficient from which you can compute metrics which should be, again, accurate and predict, for example, the retinal image, so you can address complaints such as halo, glare, monocular diplopia, etc. And yet, if you look at that example, it's one out of many. If you do refractive surgery, and when you address patients with complaints such as, doctor, it's fantastic, I'm spectacle free, but at night I have halos. If you do a wavefront acquisition. You'll be surprised sometimes that you find coefficient quite elevated. Tilt may not be a big issue because it doesn't change really much the image quality, but it's first odd that you have tilt elevated in a patient. But what's most really intriguing here is that you can find that despite the emmetropia, the patient has a very high myopic defocus coefficient, whereas the eye is emmetropic. Of course, you have positive circular aberration, which pops up here, and that expected because of the halo. But that could be still acceptable. But what's not really acceptable is that if you ask the wavefront aberrometer to compute a simulation of the retinal image, it really does not fit what it may be on the actual patient's retina. As you can see here, for higher order, that is just the higher order. So for a perfect corrected patient who sees 20/10, the visual predicted quality is poor. So there's a problem here. And the problem lies in the mathematics, in fact, of the Zernike's. What is a low order aberration is a quadratic function. You know, it's a proportion of sphere or this kind of chip shape here, but it distorts the center of the wavefront predominantly. And that can be corrected by spectacle. On the other hand, a higher order aberration is usually flat in the center. It does not interfere much with refraction, but it degrades visual quality for large pupils. And if you take a pure cubic function or a pure R to the 4th power, that's what you have. But with the Zernike, there's a mixture in some modes with low order terms. There's also a confusion usually between modes and term. Mode is the whole equation. A term is what's in the equation. But you can here see that there's defocus in Zernike, and that's not negligible at all. So that explains a little bump in the sombrero, whereas we should have a flat center here. So again, for this reason, and you can see in the pyramid, some higher order mode are flat in the center here on the side, but in the center and the closest you get to the center of the pyramid, they show central distortions which drift away from what the higher order aberrations should be. So for all the listed reasons here, we should move away from the Zernike's, and we proposed recently a new revisited classification where we have kept some Zernike modes on the side of the pyramid because these are fine, they are pure in their radial degree. But in the center, as you can see now, if you compare, you find that the modes have a flat center, so they don't interfere much with paraxial refraction, and yet they have distorted periphery as they're here for that, but again, in probably simpler manner and simpler shapes. There's a clear cut, in other words, with the low and the high degree aberration. We have just published in the JRS a paper recently, which is open access, and it drives through clinical friendly expression the role of these new modes, which again are flat or actually in cross-section here. So I think it's important because what you need as clinician is something which is really matching what you expect for pupils, like in the human eye, which are small or large depending on the visual conditions. Whereas in a telescope, it's quite different. And you see the aperture is obstructed in the center. So Zernike may work well for telescope apertures or microscope ones, but for human pupils, it does not. So again, this is a post-myopic LASIK pupil analysis. Autorefractometry shows emmetropia. Wavefront-derived refraction from the Zernike shows myopia. Retinal image is not good. And we must fix this if we want to move forward. Again, the explanation of this discrepancy here lies in this slide. This is the actual wavefront of the patient on the left, but because you have a Zernike decomposition for which the spherical aberration has defocus, you must balance that defocus. So you introduce an artifactual or artificial defocus coefficient just to make the Zernike flat here. But it's confusing for doctors, and it should not be this way. And also because you compute a retinal image with defocus inside, it blurs the image like myopia blurs the image. So it's not really doing good. So in the new classification, the spherical aberration mode is flat in the center. You see there's no distortion, there's no defocus embedded. So if you now analyze the same eye as we did before with the new modes, you see that still you can really see spherical aberration. The coefficient is much larger because Wernicke's, because of this mixture, minimizes in fact coefficient for some modes. Coma also is more rendered because there's no minimization like with the Wernicke's. There's no more tilt because tilt was an artifact due to coma, and defocus is now low and matches the clinical refraction. This is the Wernicke predicted higher order image for a 2020 patient, does not look good, but with the new classification for the higher order, you see what happens. Still good sharp image, but low contrast, but still high frequency spatial resolution here. This is also when you derive other metrics. Spot spread function shows what really happens. Bright center, but a faint halo of defocus light around it. In the Wernicke, this is not really what's the realistic image prediction. You will underestimate your MTF, and yet with the new classification, you will probably have a better evaluation. So if you realize this, it's exciting because since 20 years, we have been using metrics which provides us with not or very suboptimal best corrected image quality. And when you read papers which uses Wernicke, you are sometimes a bit disappointed because their conclusion should be revisited. I go briefly on this, but same, we have other interactions between coma and tilt, which explain this tilt issue, which is another artifact. So what's most important probably for refractive surgeons is this classification is also conceived to design better aspheric and presbyopic correction. Why that? Because if you just play with Wernicke, you cannot really separate what you want to do with the higher order aberration, which is paraxially neutral, but influence the refraction in the periphery, and the defocus that comes with. And the defocus that comes with is 4 times in coefficient titration what you have with the spherical aberration. It's huge. And in a nutshell, positive contains hyperopia, negative spherical aberration contains myopia. So it's a big headache if you want to fix presbyopic eyes using this kind of metric. It has also given rise to interesting discussion in the past. For those who use Alcon lasers, they know the C4-C12 interaction, which are exactly what Alcon had to fix. And this is really caused by a simple mathematical suboptimal thing. This slide, I think, is the most important one because it helps you to understand something which is not really well explained in literature. Yet, orange is the wavefront, blue is the refraction effect of the wavefront on the pupil. So blue can be read in diopters. With the new classification as compared to the Wernicke, there's no central myopia because there's no bump. The wavefront in orange is flat, so it's paraxially free, but you see how it modulates the correction toward the periphery in a simple way without interfering with the central refraction. So this is what you can really use now to do presbyopic aspheric correction because you know what you put in the center, you know what you put in the periphery, so you know the gradient of the refraction much better than with the Wernicke where you have a shift. And we have submitted a paper where we show that when we modify the asphericity using aspheric profiles, we are neutral with the LDHD focus, whereas the Wernicke shows like a spurious interaction with the Z40, and still we modify accordingly the LDHD. Also noticed by a nice chance that the amount of micron is very close to the dioptric. So you can read almost 1 by 1 on a 6mm pupil what you do in terms of coefficient with the new G40 to what you do in diopters using the same kind of unit. And finally, we published also a paper where we could really relevantly analyze the interaction between higher order and low order aberration. Dozens of papers have been written on that, but I think they are all, again, making a big assumption is that higher order aberration are pure and really specifically higher order. But when you think about it, the higher order coefficient, a mode in the Wernicke for astigmatism contains a lot of low order astigmatism. So if you introduce this in a kind of, I don't know, aberrometer or a simulator, you will introduce, but you don't know that, a lot of low order Wernicke. This is not anymore the case with the higher order modes for the new classification, which are very flat in the center. So to finish, I just show you a patient coming for monocular diplopia from first keratoconus because he's rubbed his eye a bit too much. Ask the patient, what do you see? Can you draw the smeared image you are perceiving? The patient does it. And when you do the comparison between the Zernike and the LDHD, there's an exaggeration here because of the low order astigmatism, which is coined in the high order astigmatism. Here you see it's more realistically matching the patient's drawing. This is another eye example. You see Zernike predicted, LDHD predicted, patient's drawing, again, more accurately rendered with the LDHD. This is a paper we published in scientific report where I'm going to cover this in 2 seconds. But again, here what you can do is now try really to address the question, what kind of higher order content affects low order content? Because in the past, again, for all these interactions, you had like artifactual answers. And what we found in this paper just published as well is that if you use artificial intelligence and the new classification, you can improve the prediction of subjective refraction. But what's very interesting is that you now can see the importance of the feature which influence. So for defocus, spherical aberration, of course, influences the prediction of the defocus. And you can see also that coma, trefoil influences direct or against the rule astigmatism, and other modes here are influencing oblique astigmatism. But now you are sure this is really the higher order aberration, not a mixture of hidden low order aberration coded in the high order one. So I think for all the reasons I exposed to you quickly, there are many expected benefits because it's, in one word, a new Wavefront basis which works for human eye, it's conceived for ophthalmologists, and it should allow us to improve the design and better anticipate the effect of sphere and cylinder of customized correction in the future. I hope so. Thank you for your attention.
Thank you, Damien. That was really interesting. And I know Michael has, we've said Michael's going to ask, see if Michael has a couple questions, but you talked about revisiting higher order aberration. Why do you think that it's fallen by the wayside as a way of guiding refractive treatments today?
Mm-hmm. Yes, I think again the problem with refractive correction when they said to be customized is that when you treat specifically the higher order wavefront addressed through a Zernike decomposition, you are retreating the low order a second time or part of it. And this is something well known for those who use some lasers companies who are this obligation to provide you with compensation, little rules, so that when you correct the high order aberration, you have to remove this and that in the low order. This may also explain much better why some patients with coma and astigmatism have an influence on this. I mean, you can address questions with a clearer view than with the Zernike, which are not really good for that.
Michael?
Yep.
Thanks, Damien.
Damien, as you know, I'm following your work for quite a while, and I'm really happy you stepped into this. I think we want to ask quite a simple question because, you know, we both have been involved in the early days of Wavefront back in 2000. We were very excited. You know, there was the eagle eye discussion. You know, we were creating supervision, and then I think we went into a phase of frustration because we did all these wavefront measurements. Clinicians started to use Zernikes, compare the metrics with what they observed clinically, and there was a mismatch. And I think it created a big disappointment in the wavefront sensing. Now, my question here now is, from your clinical perspective, do you think we have to rethink Wavefront? Is that Wavefront 2.0 coming for clinicians by understanding better the metrics? I think we went the wrong pathway in the clinic with the metrics. Do you think we're going to see more of Wavefront technology coming back and as a second wave, as we modern terms we use it? And because of the different interpretation of the data?
Well, it depends on what you do with the wavefront. I think if you are speaking about clinical decisions, of course, yes. And as you know better than me, if you do adaptive optics, the problem is not what you analyze because you want to compensate a wavefront error. So Zernike can work very well in some areas. But again, if you're a clinician and you want to match as closely as possible the clinical refraction with the low order aberrations, because that's what you treat in non-customized treatment. And if you want to do also customized correction in two ways, for example, first, to improve the vision, you need to have specifically something which does not interfere or as little as possible with refraction. And if you do presbyopic correction, you need something which is not ambiguously bringing some defocus. Like, you know, all these discussions for the last 20 years in conventions where people come and play with spherical aberration and they claim they do higher order customization. But in most cases, what they were doing without knowing it were just introducing myopia in the center of the pupil because there's myopia in the center of the Zernike spherical aberration. So I think this should be completely rewritten with a fresh way, and we can keep Zernikes for some application. But I think when it's for clinically interpreting patient's vision, retinal image quality, and also measure the titration of the wavefront. You know, we have coefficients, usually it's 0.1, 0.2. It's minimized. It's not accurately giving you the titration of what you are looking for. Comma is divided by 3 with the Zernike as compared to what it should be. Spherical aberration is by 6. And if we move in this new classification, we find metrics which are closer to what we use as diopters. So spherical aberration is typically 1 or 2 micron. And I think that would be also easier for clinicians, although they would have to forget a bit what they've learned with Zernike. They would feel more confident to bring units which are not 0.0 something, but 0.5, 1, 1.5, etc., etc.
Thank you so much, Damian. It was really amazing talk. Now we will move next speaker, Filomena Ribeiro. Thank you so much, Filomena. I'm really looking forward to listening your talk. Filomena will talk about functional vision preoperative evaluation. This is really a very interesting topic. We are listening to you. Thank you so much again.
Thank you so much for having me here. It's a pleasure to be with this whole panel. And good afternoon for everyone from Lisbon. I would like to share my my screen, but I think it's Damian who blocked it.
So you should be able to just go ahead and share it, Filomena, because it's open. So you should just go ahead and start sharing and you'll be fine.
Let me know if I did something wrong.
No, it should be okay.
It's okay?
We're okay. Yep, we're good.
No? Okay, so we like to talk a little bit about what is functional vision. And I think in our days in cataract refractive surgery, we have this great opportunity to retrieve the patients all the functional vision for their life. But we must understand this, of course, and do the proper pre-op evaluation. So behind the biometry, behind the IOL power calculation, different formulas, we need to assess, of course, the ocular pathology of the patients, but we need to understand what are the patient needs, of course, to fulfill the patient expectations. And we have several IOL solutions right now, so we need to improve our pre-op evaluation. But first, what we really need is to rethinking the definition and the clinical relevance for all these concepts of different distance of vision, which translates in functional vision for all day long. We have this working group in the ECRS. We are trying to a little bit input this concept. And I think it will be very, very relevant in the future. at least for the patient counseling process. We need to improve that. And we know for some literature that the doctors still are not so confident in explaining the optic design like multifocal presbyopic correction IOLs. Also, we have a few minutes to do it, so all translate in difficulty to explain to the patients, and they reclaim, they demand more information about it. And we should keep this in mind, because I think that even if we select to this patient to have a monofocal IOL, for instance, we need to inform this patient why we choose that option, why this option is the best solution for him. So we need to have more information. And there is a huge development in presbyopia correction IOLs. And one thing that we learned with bifocal IOLs was that patients complained about not having intermediate vision, which is in our days with so many digital devices, our lifestyle is changing a lot. The people work until very late in age, so we need this ability. And we see the development of the IOLs is even trying to improve this intermediate vision with the EDOF lens. We have several right now with different defocus curves. We have also monofocal IOLs, which they are advanced because they have a little bit of correction of intermediate vision. And also the trifocal evolution is towards more intermediate visions. So we should understand all of these, know all of these IOLs to know which one will fit better my patient. If we see, for instance, for the same group of IOLs, and these are all trifocal IOLs, and we can see that they have a split of energy for far, intermediate, and near vision different. So we need to understand that to choose the best solution for our patients. And they also have different points of best focals for near and intermediate vision. So it's a lot of information that we have to process. We understand that there is different focus curves, but how they fit to our patient's daily life is what we need to understand. Because we can even manipulate a little bit with some small offset of target to manipulate all these defocus curves, but how these fit our patients. Really, we have a few instruments to assess all these important information. We have some questionnaires, but patients, they really have some difficulty to respond these questionnaires. They are too subjective. We have some measurements like the hand length, the arm length. It's not enough for us to choose the best solution. So I think that is important because we are doing surgery really more early in the life of the patients. This IOL will be a lot of years, so the results are permanent and also the consequence of our choice. And there is some variability between the patients about what they need, the different distance, and the amount of time they use different distance. So mandatory to determine the optimal IOL design for each patient, but the most important, and I think we have a consensus right now about this, we always should involve the patient, educate the patient, so they can have really realistic expectations about the surgery. I think this is really a key point for refractive cataract surgery. And that's why I would like to talk with you about this innovation that we have incorporated in our clinical. We are studying that, but I would like to talk about my experience, my clinical experience with this device. It's a sensor that can measure viewing distance of the patient and light conditions. So they use these different distance. It's coupled with in the spectacles, is very user friendly. The patient need to charge this device at night, and all day is using the device. It's measuring all the distance. And at the end, this device can retrieve us this graph. As you can see, is very visual for the surgeon and also for the patient. And what the information is very objective. We know the frequency of the patient's view distance, different distance as you can see here. And this is very useful for us to understand the visual needs of the patient. It also can give us the light conditions in which these patients are using near, intermediate, and far vision. It's like a combination matrix of all these values. I would like to show you some examples of these. And the important thing here is we have the perspective of the visual needs of the patient, but we need to match it with the focus curves that we know from the different kind of IOLs that we have. So we can use that with the focus curves for different IOLs or even our own the focus curves, but also we can go ahead with mix and match the focus curves with target offsets as I showed you before, and also with monovision. Why not? It still is an option in our days. So if you see this example, this is a patient. She used this device for 4 days. We have here all the graphs, and then we can have a summary of these, the use of the device. You see here, we have this graph with all the occurrence for the different distance that this patient has used. We can have it in percentage, and then we can fit, for instance, a monofocal IOL. What should correct a monofocal IOL? But we can show the patient, if we choose a trifocal, in his case, we can improve the functional vision of this patient. And we can try an EDOF IOL. And in these cases, the EDOF IOL was the preferred choice. And at the end, we have a report in the patient language that explains all the process to the patient. So it's very informative for our patients. Another example, you see 4 days of use of this device. So this is the same, I'm sorry. This is the new one. As you can see, this patient has more need for far vision. With a monofocal IOL, we can correct almost all, but we can try to choose a mono EDOF IOL, and we can improve a little bit, or an EDOF like VVT, for instance, we can improve it even better, or another kind of EDOF, a diffractive one, which improve a little bit. But at the end, the choice is between the surgeon and the patient. And in this case, the patient chooses a monoid of IOL. And here we have the report for this patient. We have even tried to, these patients after the surgery use this device for us to understand if the choice was really good, if the patient really is using the distance that we wanted. So this is, for instance, one example of a woman. She used the device 1 month after bilateral synergy, in this case is implantation, and we can see how this patient really used all this distance that we wanted in the pre-op correct. So answer all the questions. What problems does this technology solve? Well, I think it's a good improvement to determine the patient needs and expectations. If the innovation solves the problem, yes, matching objectively with data for choosing the optimal IOL design for each patient. And change the life of patients. Of course, it's a great way to the patient understand the impact of the IOL selection in the daily life. It's important for clinicals. Yes, we can assess objectively the visual needs, and the most important issue is allows communication with the patient. So for the end, why this innovation, why I think is the main issue is this important goal, patient education and engagement, which is very, very needed for this kind of surgery. So thank you so much for your attention. Bye. I will finish here.
Thank you so much, Filomena. It was really amazing talk. As a clinician, I had also opportunity, have experience with this technology. This is really very important. We are changing patients' lifestyle, and we have no idea what is patient lifestyle preoperatively. And to examine objectively by this way, really very important. So I would like to ask Damian if any comment about this technology. We have all, Michael, myself, and Chris all experience. What is your comment? What is your question if you have?
I'm just fascinated. It's a thrilling thing because, as you said, when I discuss with my patient, I'm always surprised by when you ask questions like the notion of seeing far away. For myopes, far away starts 2 meters away. For hyperopes, it's 200 yards away. So when you know, so even this is very important because again, for the myope, there's not the same scale. It's like a bit of Zernike versus another classification. So you cannot trust patients in their assessments when you discuss these things. You need some objective metric, I think, for really knowing what's going on. And it's a multiple dimension tool because you have the distance range properly assessed, I believe, but also the time dimension, which also patients do not really consciously appreciate well. That's again something which is really needed. Now I have another comment, but I'm so biased that I almost do not dare. But don't you find that patients usually do not want the distance, the near and the intermediate, and therefore this kind of instrument, and this is not why I like it first, because I didn't use it, but would probably rise up the level of trifocal IOLs, for example, or at least full range vision IOL. Because when I discuss with my patient these things, at the end they say, you know, if I can have a bit of distance near and intermediate, even if I'm doing more this than that, at the end give me all the thing and I will be fine.
Yes, I think this is the perfect instrument to explain that to the patients. It's true. At the end of the day, they really want everything. If I can have everything, why not? With this image, this graph, they can really understand that there is no perfect solution, and they can understand how can we fit to the objective of their lifetime of them and the job, all the hobbies they have. So the perspective here is really answer that question. People understand that there is always trade-off and that we can fit better with some kind of solution.
And do you have now statistics on a large population? Did you start, because that's a new area also in visual optics, again,
Yes.
the integration of time, distance?
Yeah, we start a study with the device. I only report here my personal experience, clinical experience, but as soon as we have the data, we will give you everything.
Because what could be good if it was embedded in children? You could, is this myopia, knee work is related, etc. So you could find also trends which are related to the ametropia. Correlation, at least. Causation is more difficult, but that would be interesting also to find that.
Yes, of course.
Michael, isn't there, whoops, where'd Michael go? Isn't there a study going on up in the UK looking at myopia in children?
Correctly, I need to disclose that I do have a financial interest with Vivio, but there are studies going on. We did the study on children and progressive myopia at the university in Istanbul, as well as we're supporting a bigger study in the UK.
Okay, great.
It's a promising.
Yeah. I see Ike, are you ready to go now? Do you want to jump the queue? 2 minutes.
I can go now, or I can go after Ash, whatever you like. I can step out.
Okay. You're all right? Okay.
These guys are hopefully okay.
Okay.
There's a posterior capsule protector I need from Tobias, so that way I don't have to go back and help my fellow. I could use it. I apologize. I have to keep a mask on. I'm in the OR, but everybody, how's it going? So thank you for the opportunity to speak. I wanted to thank Michael and Eileen for asking me, and I initially said no because I'm in the OR, and as you all know, the OR situations are quite variable, and we only have a few days we can work, but this was important to be part of. So thank you for asking me to be part of this. And of course, it's an honor to be here with everybody, except Keith Barton, who I'm not sure why he was invited, but he's going after me anyways. I am going to speak about something that really excites me, which is already in clinical use, but also is being evaluated in the preclinical world, and that is intraocular IOP sensors. There are many ways to measure pressure, and I'm going to focus on this. I do consult with a few companies that are in this space, including InjectSense and Glaukos as well. So, of course, we know that glaucoma, a leading cause of blindness, asymptomatic and insidious, and intraocular pressure is associated with damage. And it's a significant risk factor, and our treatment, of course, is based on this only modifiable risk factor. We, of course, aim to get low pressures with consistently stable postoperative IOP, and we know that medication adherence is also poor and increases the risk of progression. IOP, of course, is a part of every single glaucoma assessment around the world. It's typically done in the office with a single measurement, and of course is faulty because of the issues around the assumptions on the Imbert-Fick principle. It's also, of course, impacted by corneal biomechanics. And we know, of course, in a variety of studies that pressures do fluctuate significantly and often are more elevated at night when we can't measure the pressure than during the day. Conventional thinking is that typically peak IOP is where the damage typically occurs in glaucoma. Although it's somewhat controversial, it's these peaks that are likely most damaging to the retinal ganglion cell optic nerve complex. And this is where the progressive damage can occur. We also know these peaks can often happen outside regular clinic hours and may not be caught during just a single measurement. The downward curve can also miss this as well. And a single pressure measurement, of course, is a very small time point during a patient's day. I apologize again. There's a code white. That means a violent patient. Now, we, of course, see different ways to measure pressure outside the eye. For example, rebound tonometry, we see the variation in pressures, even measuring them during daytime hours. So the problem is IOP assessment. Our current measurements require patients to make a visit in the office and have appellation measurements, which, of course, during this COVID era is a problem. It's non-physiological, inaccurate because of imperfect assumptions, and a single measurement is inadequate to capture the full IOP range and miss peaks. Of course, we also cannot assess compliance by measuring a single time point when a patient may have taken the drops right before the visit. The solutions and principles here, and there's a variety of companies in this space, is the implantable IOP sensor. We're able to, the goal here, of course, and the principle is to directly measure pressure in the eye real time and continuously. There are various ways to do this using active or passive sensing, wireless charging necessary, of course, because the implant's in a closed system in the eye. We have to get the data out by telemetry. We need to, of course, preserve tissue as much as possible, make it biocompatible, minimize the disruption of the patient's lifestyle, and have a long-acting product. These are 4 companies that are currently in development or have a commercial product: IOP Implant Data, Cora, InjectSense, and Glaukos. The sensors that are in development are either preclinical, animal, human, or commercial. A lot of these companies are operating fairly quietly, so there's not a lot that we can publicly speak about, but I'll speak about what's available and what we know. Of course, there's a variety of places these sensors may be placed. We can think most obviously, of course, in the anterior chamber, in the vitreous cavity, attached to an IOL. These are all typical places that we may look to in terms of where we may be able to measure, also the suprachoroidal space as well. Now, designing an IOP sensor, of course, is fairly complex, relying on engineering principles, surgical principles, and others, other material differences. Typically, this includes a MEMS sensor, mechanical electromechanical sensor, application-specific integrated circuit, and these can be either using active or passive electronics. These have to be fabricated in a biocompatible coating, typically, and miniaturized, of course, to be in the eye. It's, of course, important to have an ability to wirelessly transfer and charge the implant with an external reader, typically, and ideally, these IOP sensors are autonomous, don't require patient interactions. We have to also compensate for drift as well over time, as these implants typically will reside in the patient's eye for many, many years. Active IOP sensor uses active transistors and diodes. This does provide a greater precision and reliability, but does require more power consumption, and we have to consider warming and temperature changes, typically done with a rechargeable battery. Passive IOP sensors, like resistors and capacitors, are less complicated and less power in terms of demand, but require, of course, frequent charging and wireless energy transfer of data. The iMate is probably the most widely known current IOP implant. As you can see, and this is a sulcus implant made of silicone. It's an encapsulated capacitor here with a thin diaphragm that basically deflects the pressure. This is read by an external source, transmitted by radio frequency, and it can allow for frequent measurements. These are just some examples in terms of what the iMate is currently in, what its form it's in. There's a sulcus implant you can see that's already CE marked that can be placed in the sulcus or possibly the capsular bag. And then there's a product in development that is designed to be into the supraciliary space, suprachoroidal space, which is current in development. Here's just an example of the video on the bottom left showing this sulcus implant, a familiar space for many of us, where it would reside typically, of course, in a pseudophakic eye, either in concomitant or after cataract surgery. The ability to place the device in suprachoroidal space allows it to be placed here using an external dissection. Of course, as I mentioned earlier, it's important to have and collect the data, and this is typically done by a reader, which also charges the implant as well, and the data is collected and then can be provided in a proper format for evaluation. Data has been published here with the Argo studies with the iMate, and we can see long-term IOP monitoring with fairly good levels of agreement with Goldman appellation tonometry, and of course, work still has to be done in terms of looking at the correlation here as well. And one of the benefits is really being able to evaluate when these peaks may occur in a 24-hour period. And I think this gives us substantially more data than we currently get with current IOP measurements. Cora has an implant that's been implanted in animals. So you can see it's attached to an intraocular lens in this case. And further work is being done to further miniaturize this to be able to provide the implant in other parts of the eye as well, standalone. This again is a system that's designed to wirelessly read pressure and charge the implant, ideally without patient interaction, fairly autonomous, with simply, for example, a bedside external sensor or source that can be used to collect the data and charge as well and upload the information to the cloud as well. InjectSense is another device that's currently in preclinical work. And as you can see, this device is placed here very much like an intravitreal injection. This is more of an office-based procedure as opposed to a surgical procedure that we've seen with other designs as well. Again, the idea basically that this is an autonomous data collection that is obtained either with a pair of glasses or another source, uploaded, of course, to the cloud, and then, of course, relayed to healthcare providers. So from a patient's perspective, I think this reduces the uncertainty of the disease. Is the pressure controlled or not between visits? It will reduce likely the need to get back to clinic to measure pressures. Of course, we still need to be evaluating visual field and optic nerves. It possibly eliminates the need for applanation tonometry. And of course, the idea is we can proactively now identify the patients that may be peaking that we can perhaps treat more aggressively, eventually improving quality of life and of course, providing further cost savings to the system as well. From our perspective, of course, this is the holy grail of glaucoma and the holy grail of IOP monitoring. Continuous IOP monitoring, of course, will allow us to hopefully adequately assess risk assessment for a patient, decide on the best medical and surgical therapy, and I think also acts as a compliance tool. Is my patient taking their drops? We'll be able to look and see, of course, in terms of how the IOP control is. And of course, the ability now to use big data and AI, of course, adds further benefit here. There are certain corneal conditions where it's difficult to measure IOP, it's not impossible. Like for example, patients with keratoprosthesis is an obvious one. And also surgical real-time measurements during VR or cataract surgery may be a benefit, again, to provide enhanced fluidic control in the eye as well. We also know that there's an increased incidence of glaucoma in patients who have intravitreal injections, and this is the ability to measure this, of course, during these injections and assess for potential acute IOP spikes. So why am I excited? Well, I think this is, again, as I said, this is bringing IOP to the digital age, right? This is 2020. This is the holy grail of measuring IOP. Goldman is quite antiquated and really not appropriate, I think, in today's world. This can also provide an ability to provide enhanced IOP metrics like percent peak or area under curve, for example, that may be more relevant than single measurements as well. And as I said before, big data will, of course, guide us as well. The ability to provide this as a feedback loop to link with drug delivery and outflow devices, again, to control aqueous flow will be the ultimate, very much like we see, for example, in the advanced diabetic monitoring and treatment devices. Surgical IOP monitoring, as I said earlier, and of course, there's also other applications in the body, including neuro as well. So quick summary in terms of why I'm excited about IOP sensors. I apologize for being in this getup and being in the OR, but thank you again for having me here.
Thank you so much, Ike. Very, very nice, very excited talk, very nice topic. I will ask very quick question. As a refractive surgeon, I am asking this. I apologize. This is really very different technology, very different field for me. Your implant is into the eyes for a period or long term? How long period will stay in the eye? And another question is, you implant is which patients? What is indication?
Yeah, great question. I think the first question is yes. I mean, that's a very good question as far as the duration. These implants are hopefully designed to be in the eye and be active for 10, 20 years. There is, of course, it's important to compensate for drift, which typically would occur, and there's ways to compensate for that, as well as fibrotic growth over the implant as well. But the idea, of course, is to have this implant, at least in these current designs, longer term. Now, there are other ways to look at it for short-term evaluation that may not be as stable, but the value here really is for longer-term evaluation. That is still, of course, something that is still needs to be evaluated as far as the durability of that approach. In terms of the other question was in which patients. I mean, I think ultimately, really, anybody really who has real glaucoma needs to have the IOP measured. Anybody where we have to make a regular IOP assessment and we use that in terms of disease management, I think is a candidate for something like this. Obviously, if we're already going into the eye doing cataract surgery in a glaucoma patient, this provides an opportunity since we're already in the eye. I think for patients perhaps that are progressing and have normal tension glaucoma, that we're not quite sure, are they not compliant? Are they spiking? Are they peaking? Or they truly have not normal pressure glaucoma or a non-IOP mechanism? It can be useful in those patients. So that will probably be the first wave of patients I think that we look at particularly. And obviously in your world, in the corneal refractive world, anybody who's got really bad corneal pathology, keratoprosthesis, I mean, that's an immediate first place to look for, of course, in terms of where we would think about these devices. It's already, of course, being done and published in K-Pro as well.
Thank you so much. Keith, do you have any question, any comment?
Unmute Keith. Yep, oh, there you go.
This is obviously the the future, and it is one of the most exciting innovations. And it's we've actually been waiting for this to come along for some time, because any kind of intraocular sensing will be a game changer. Ike, can you foresee these getting into phakic eyes, for instance? Obviously, cataract surgery is the low-hanging fruit, but are any of the devices you're working with really going to be suitable for phakic eyes, or is it purely going to be, for a long time to come, purely going to be limited to cataract surgery?
I think it's a good question. I mean, the hope, of course, is that it'll be a broader application, and the designs that are attached to lenses, of course, are restricted in that way, or to a capsular tension ring. However, some of the companies I just mentioned are working, for example, on a transscleral pars plana approach into the vitreous cavity. That would, of course, be a patient that wouldn't require or be done with cataract surgery. Other companies are working on an anterior chamber implant or angle-seated implant. Those would be examples where we would not need to. And of course, also, as I mentioned, suprachoroidal measurements, if one looks at that aspect of it as well, are avenues. So I think we all have the pros. We all have what's that?
That would be very different. It's negative.
Yes, I mean, there have to be a lot of compensation, and there's a lot of pros and cons in whatever approach we use, whatever space we do. But again, those I think are where they are. And we can, of course, debate whether we should be looking into the vitreous or suprachoroidal space or anterior chamber or capsular bag. I think those are all good questions that I think we still, of course, don't have full answers for.
Yeah, this is such an exciting area. The other challenge you mentioned already about fibrosis, how to actually power the things. And I know that some of them work on induction. I presume there isn't any that's depending on some kind of battery. That's completely unrealistic, I guess.
Yeah, I mean, there's clever ways to charge these devices, and in fact, rechargeable batteries have come a long way and miniaturized. They do, of course, limit the duration in terms of which they'll be usable. But the way, we've all seen, our iPhones in terms of how they progress with battery life, and I think the same thing we're seeing now in the ability to attach to a MEMS device as well. So I think that's where we are seeing miniaturization and longevity with novel ways to charge, which is what I think we're seeing in the preclinical work.
Brilliant, great presentation. It's such an exciting area, and it'd just be nice to see something getting a little closer to clinical practice.
Absolutely. Stay tuned.
Yeah.
Okay. Thank you so much again. Have a nice surgeries. Have a nice day. Thank you so much. Between surgeries, joined us.
I still want to listen to Keith Barton. I never miss an opportunity to listen to Keith Barton. So I'm going to listen to him while I'm operating. So all the best, everybody.
Perfect.
And Ash as well.
All right. Thanks.
You've heard it all before.
Now, we will next speaker, Ashwin, will talk about advanced vision analyzer. Ashwin is very famous international speaker, very good refractive cataract surgeon. And from India, now he will inform us a very nice future, maybe visual fields assessment. Thank you, Ashwin, join us.
All right, thank you so much, Eileen, Michael, Chris. After Ike finishes beating up his OR stuff, I'm going to start my presentation. I'm going to be talking a little bit, taking off from glaucoma, from where Ike already presented on IOP as one of the most important diagnostic procedures that's required for glaucoma. I'm going to be talking about perimeter and revolutionizing perimeter in a different way. I must confess first, I have a financial interest in this topic, the Advanced Vision Analyzer. It's a diagnostic device which basically helps us measure the visual field for a patient. How does this machine work, and how does this machine work? Let's just go through with the program. Can you guys see my screen?
Yes.
Okay.
Yeah, we're good. Yep.
All right. So let's just define the components of this device first. It's got a headset, it's got a clicker, and a tablet. So the head-mounted device basically presents the stimuli to the patient. The patient responses is received by the clicker in the right hand or the left, and the monitoring and you monitor and assess the assessment on the tablet. That's how this whole device really works. What it also has is the headset also has an eye tracker in it, which basically tracks any movement of the eye from the gaze that is required for this test to happen. The most important over here would be this wireless control of the tablet, the cloud data that is backed up. That means all the test report actually gets sucked up in the cloud, and all the software upgrades that need to come in are actually just over the air, and really you don't have to send the device anywhere, or no real software has to come from somewhere else. Some of the big advantages, I think the bag kind of explains why this device is more portable in its own approach. So we'll take you through that. But what's the problem that we are trying to encounter over here is perimeter. We all know perimeter, and I'm not going to define what perimetry is, but I'm going to tell you that it's going to be used in diabetic retinopathy, in cataracts, retinitis pigmentosa, glaucoma, macular degeneration, and you know the whole shebang on that front. Where visual field is required, you need to do a perimetry. What's the challenges that we face today in our today's devices? I think a couple of challenges is it's a bulky device. And when it's a bulky device, it restricts the movement of the device itself to the patient. Rather, the patient has to come to the device. That's one major issue. Second thing is postural difficulties. Before postural difficulties, I would tell you that this bulky device also needs a dark room, and that is a must in these in doing any form of perimetry in today's world. Postural difficulties would be people with kyphoscoliosis, back pain, because you know it takes in our ORs or in our clinics, it really takes about 20 minutes for someone to do the test. Kyphoscoliosis, back pain, pregnant women, kids, children, pediatric age groups. These are cases where, you know, I've seen personally that I've not been able to complete the test because they just don't want to do it. High cost of this device is another big problem. And the majorly huge number of undiagnosed glaucoma patients because they just couldn't do this test. And we all know that this is pretty much a confirmatory test that is required when you want to confirm a patient for glaucoma. Going to how it's actually portable, it's basically taking that whole big bulky device and converting it into a VR headset. So basically removing the whole traditional way that we've actually used VR, the bulky devices, and the high cost of the capital equipment that is completely changed. The other aspect of here, which I think becomes very important to understand, is the separate dark room requirement that was always there and now suddenly has gone away with this device. One of the biggest advantages, when I say portable, I don't mean just portable to other places like screening camps or anything like that. I'm talking about even in your clinic, you really are making the patient move from the waiting room area and into a dark room. That's also a cumbersome experience because that's one device that one space is required to be dark room. You have to create the room basically towards having that glaucoma test done. Now you can actually just give the headset and it's a get-go from wherever the patient is sitting. So portable does not mean just out of the clinic. It means even in your clinic, it's portable. Next up, I think it's a head-mounted device. It's flexible, so you actually can make the patient sit down on a sofa, lazy boy. I mean, I've put a lazy boy in my in my clinic, so it really becomes easy for that patient. Old patients and pediatric age groups are really finding a little more comfort with this device. Next up, I wanted to tell you it's rather simple. When I say simple, you can monitor all of the tests just by simply holding that tablet in front of you. You know where the patient is gazed. You know when the patient is not focusing on what you want to focus. So, and it's all happening over a device. All the reports are in through the device, and your infrared tracking of this gaze monitoring is all happening through the tablet itself. Again, reports are also, I'll come to the reports soon. But one of the best parts of this product is actually there's no learning curve. The best part is because of the familiar report output. So the report looks exactly like how you actually view any of your reports today from the Humphrey, which is what I think these guys have taken from to make it as a template. And what they've done is basically built on top of this a normative database that uses the international standard, that complies with the international standard. In terms of comparisons, I think this is an important aspect here. I think what happened is we compared the visual field measurement on AVA with Humphrey for all the algorithms there are. And the global indices like mean deviation, pattern standard deviation, what we found was statistically equivalent. And that was beautiful to see that a device could actually replicate exactly what we have found on an Humphrey. It was all possible. So basically what I'm trying to say is using these 800 subjects, we were able to find that it was possible to get similar visual field outcomes when compared to the Humphrey device. This was a huge game changer when it came to this product and its results. What are the algorithms that we have? Foveal threshold, gaze monitoring, your test patterns 24 to 32, 10-2, and also all the strategies that are including your screening, your full threshold, ELISA, ZEST, and FAST. Exactly like, so again, there's no real learning curve except for the learning curve of how to make a patient go through this experience a little differently from what we've been going through with a chin rested device, which is not there anymore. Connected, what does connected mean? Connected over here is basically we have the tablet that really you can search the patient by name, phone number, email. It's all on the cloud. You don't have to go anywhere. And even you can send the data. If you're sending a technician to someplace, you can send the data over the cloud and the doctor reviews that data, gets back to the technician, and you're able to give a diagnosis, everything just over the air, over the internet. Software upgrades can be made over the air. And this is a huge game changer when it comes to, getting new products or new features into the product. Like the 10-2 is just coming up in the next 30 days. And that'll be all over the air for the people who've already have these devices. Nothing else needs to be added to it. And all the clinical data is encrypted, so it's pretty much safe. You really don't have to worry about the patient data over there. All in all, it's now a perimetry is now portable, simple, and accurate. And I'll also add another word, safe. The data is safe with you. And this was the presentation that I wanted to show for glaucoma diagnostic. Any questions? Happy to take them, as many as there are. Oh, yeah. Yeah, go ahead, Eileen.
No, go ahead, Ash, and then I'll ask somebody who's written in a question for you.
Sure. One big piece of advice is this product is now US FDA approved. Yeah, we wanted to mention that.
Ashwin, how does it take? How long does it take one measurement? Is it advantages or shorter, longer?
So from what I could see is initial learning curve, it was about a minute or so longer, but after it's the technician who takes time to actually convey the message while he's explaining how to go about the process. But once they're through with that, the time just reduces drastically.
Ashwin,
yes.
The device goes over both eyes, and how are you assure that you just you look with both eyes?
Yeah. And open eyes.
The right eye is checked?
Both eyes are open. It's a dichoptic presentation. So you really open both eyes. There's a filter in the middle. It segregates both eyes while you're doing it. So you really don't have to close one eye.
Yeah, that is very comfortable for the patient.
For the patient, extremely comfortable. And it also has you can put in glasses. You can put the prescription powers in. You can have the IPD adjustments. That's all in the head-mounted device itself.
So it's not glasses you have to put, but it's automatically.
Like a trial frame.
Yeah, super.
Just take it from your trial frame and put it in. Nothing else changes.
Very nice, very nice.
Is there any
Okay, we've got question. We've got, sorry, Eileen, we've got a couple questions for Ash. First question is, does it have a beeping sound like automated perimeter to help the patients maintain concentration?
Yes.
Okay. And then second question from Arthur Cummings. What is the cost per device?
I think from what I understand, it is different for different countries, but it's going to be 1/3 of whatever it is right now. From the comparative of the Humphreys, the others, everybody, it's going to be 1/3 for sure. I mean, that's one of the
Okay.
biggest advantages of this whole thing. It's portable, it's sturdy, it's safe, and it's 1/3 the cost. I mean, that's one thing that we wanted to, I think these guys wanted to be very, very clear on from the beginning.
Can I just ask something, Chris?
Yeah,
how do you differentiate the nasal visual fields where there's overlap if you're doing them binocularly?
The nasal visual field, okay, that's a really,
Because, you know, how do you know which eye is responding if you're doing two eyes?
no. The test report is going only for that one eye. So there's a mask. Yeah, it's only for one eye when
No, but how? Yeah, but it
output.
could be the nasal field. It could be responding from the other eye if you got both eyes open.
No, but there's a very clear demarcation in the middle.
Oh, there is. Okay,
inside
yeah,
the device.
okay, yeah.
Inside the device.
And so, if I understand it, the strategy, the algorithm is very similar. It's not actually the algorithms that are different. It's the portability and logistics that are different. So you're pretty much doing 24-2s. Is that correct?
Absolutely, absolutely.
Yeah. I kind of hoped, you know, that I kind of figured that if Elon Musk or Bill Gates or someone ever got glaucoma, there would suddenly be a much simpler test in the market. But you know, I mean, this is a great innovation, but it's a logistical no-brainer. But you know, if we could design some kind of software that was more like a game that could make it so much more interesting and easier for patients, we'd be going somewhere as well. But I just don't think that's ever going to happen.
No, never say never. You never know. We never know. But it's a good feedback. It's a good feedback, and I think I should give these guys that feedback.
Yeah.
For sure. Michael,
Actually, along that line that Keith just mentioned, do you think the point of where the measurement is going to change? I mean, at classical, now the patient has to come to the clinic. You have this big monster in the dark room. Do you think this can be done at a, for lack of better words, be done at home by the patients on a regular basis?
Yeah, I think these guys have already spoken to me about that, and they're already planning on launching a device that people can buy and take home as well. And that's going to be a home healthcare to this, because it's a regular, I mean, once somebody gets glaucoma, it's a lifestyle change for that person, and they're going to need this kind of devices at home itself. Why come to the office? I mean, from right now, people are already using it for home healthcare. So that's already started off.
Yeah, because we looked a lot into this, you know, using medical devices at home.
Right.
And, you know, the patient actually would rent it for a couple of days. You ship it there, you know, there's Amazon has a lot of logistics. They use it for 2-3 days, send it back. You have the data. And in 3 months' time, maybe he gets it the second time or third time. So you completely avoid the visit, lack of better terms, if needed.
Yep, that's the whole game plan there.
Wonderful.
So now I think we should move next speaker. We have limited time. Keith Barton is also very famous, like Ike, like other speakers. Thank you so much, Keith. Also, Keith is organizing very nice innovation meetings in European Forum. We had opportunity to join, and we look forward to listening your talk. He will talk about glaucoma surgery, new direction, or follow the heart.
Thanks, Aileen, and we hope you'll be available this year as well for the program. I'm just going to share the screen. So this is, you know, a lot of glaucoma surgery. Glaucoma surgery is changing. For the first time ever, there's some serious innovation. But the problem with glaucoma surgery is that we still have a lot of need that's perhaps not met by the innovation. And I want to highlight some of the breadth of need that's out there as well. So I've got to talk about what we have and what we need. And what we have is, you know, conventional surgery, trabs, tubes, new procedures. You know, why trabs and tubes still around after so long is actually because they still work more effectively than a lot of the new procedures. And the trabeculectomy and Barveld implant produce good IOP lowering. Case selection and laborious follow-up are critical for success. And a lot of surgeons nowadays who just do cataract surgery actually just wet themselves at the sight of blood and just don't really like anything that involves an awful lot of blood. And on top of that, to be good at this stuff, you need to do a lot. You know, if you were doing 1 or 2 phacos a week, you wouldn't really be a very, very slick phaco surgeon. And it works with these as well. You know, but nobody does 20 Barvelds in a day or 20 trabeculectomies in a day. And that's part of the problem. So new procedures are taking over. There's lots of them. There's a plethora. And I'm going to highlight Schlemm's canal because that's the most crowded space and the one that's received the most attention. We've got the stenting procedures, which are elegant, minimally invasive, and actually backed up by randomized clinical trial evidence, thanks to the companies and the FDA. We've got the cutting techniques, which often are cheaper, a bit more dramatic in terms of early pressure lowering. Absolutely no randomized clinical trial evidence whatsoever, but they're in that space. And then the ABEC, which is like a dilating procedure, but again, no evidence. I highlight the trial evidence. We know what it is. These are modestly efficacious devices, but again, they're elegant. We have data, and they're not messy. What do we need? Well, we have patients with progressing field loss. We have less advanced disease who need cataract surgery, and we have complicated patients with failed surgery and very high pressures. We've got a wide spectrum of people in glaucoma. You know, cataracts vary as well, but they don't quite vary to this degree. And traditionally, the little video thing's in the way, I can't see what I'm doing. Traditionally, we've had trabeculectomy and cataract surgery and trabeculectomy. And in this group, it worked well. In this group, it was completely inelegant surgical overkill. And in this group, it was totally useless, but we still did it because we didn't have anything else. And now we have MIGS. We've got hydrous, eye stents in one end of the space with good RCT evidence. We have the Zen and microshunt in the other end of the space. The microshunt is coming up with RCT evidence. But we also have patients like this. And the problem with patients like this, you have one opportunity to get it right. You don't, it's not a question of let's try this and let's try that. And the patient didn't want anything minimally invasive. This patient needs to be fixed. This patient needs to be fixed. They're at real danger of sight loss. And the idea of tweaking and twisting and doing a little bit of this and a little bit of that just isn't enough. So we need different solutions for each of these scenarios. We don't need to end up going from doing trabeculectomy in everyone, whether it worked or not, to doing MIGS in everyone, whether it works or not, because that's a paradigm shift that does not serve the broader needs of the community any more than the starting point did. And it's certainly true that things like subconjunctival MIGS are approaching the space of trabeculectomy in those with central visual field loss. We've got the Zen, the ab interno, and the microshunt, the ab externo, but both are easier than doing a trabeculectomy and a little bit less intense. The trouble is that they're still, as far as we can see, not quite as effective as a trab. We still don't have something that gets us down to the level. And this is the top line results of the InFocus study at 1 year. Microshunts achieving pressures of 14 on average, trabs achieving pressures of 11, both on a lot less medication. So they're good pressure reduction, but for your patient where you're still trying to get those magical figures of 7 or 8 or 9 or 10, actually neither achieves it on the average, but the trab still comes a lot closer, which is why a crude, inelegant, laborious operation is still around after 50 years. And this is part of the problem. And the challenge of subconjunctival MIGS, even though they seem to produce better pressures on average than other MIGS, is that they're not quite there enough, and with still limited evidence of efficacy from trials. The canal procedures are brilliant, probably for the phaco plus, as we know already, and that's why in the US they're only licensed for phaco plus. But again, with relatively little evidence in this space apart from the stenting procedures, and we really need data right across to really understand the profile rather than just random retrospective case series being produced. And then again, with the complex secondary glaucomas, those failed with very high pressures, where neither MIGS nor TRABs are any use. And we have had tubes which are actually fairly crude and haven't really evolved at all in the last 20 years. The Barvelt is still the most effective out there, but it's crude 25-year-old technology performed in high volume by a very small number of surgeons, not accessible to many patients, and the tube's too big for the eye. But actually, things are changing slightly. And this is the pole glaucoma implant from Singapore lined up beside a Barvelt. And the one, you can see the plate's not that different. It's a little narrower, like the Amid ClearPath, so it doesn't quite go under the muscles as much, but it's a smaller tube. The tube portion's not much bigger than a microshunt and a PRESERFLO. That's the PRESERFLO, that's the pole. And you can see it's getting close in size to a MIGS type device. The top one that you can see up here is the Barvelt. This is the pole, and this is the PRESERFLO. So 640 external compared with 467, 300 internal compared with 127 compared with 70. You're getting somewhere in big crude tubes. It's approaching where we hope to be, where we should be going in the long term. So perhaps inspired by MIGS or perhaps not. Even the conventional tubes are becoming a little bit less invasive. And the pole glaucoma implant, which I have been involved in the design of, so I guess I'm a big supporter, is something that I think you're going to hear more of in future. And this is the direction that hopefully, this is a direction that does excite me, because it's something that you can give to patients who have much worse glaucoma where nothing else will work, and that you actually have some chance of controlling the pressure well. So the problem with glaucoma is that it's different clinical problems. There's really, and I've broken it down into 3 simplistic groups, and there really are different answers for each group. And if you're a one-track surgeon, you really shouldn't be dealing with the 3 different groups of patients. You need to be learning more stuff, and not forgetting how to do trabeculectomies, because unfortunately in one area, trabeculectomy still offers the best hope. But what else do we need? And we've touched on this a bit. We need decent large-scale data on glaucoma outcomes. You know, as I mentioned earlier, we have randomized trials on stenting, but nothing on cutting or dilating. Cataract surgery is way ahead, as you guys know already. This is a UK data set from 10 years ago of 55,000 cataract operations. You can drill down to the risk of PCR if you've got a 30-year-old resident who's 5'9" and wearing size 7 shoes, doing a left eye, and a 90-year-old with the pseudoexfoliation. You can drill down almost everything in these, because cataract surgery has got big data together. Glaucoma surgery does not have big data together. We don't really have anything, and we're attempting to address this with the International Glaucoma Surgical Registry, which you can access by any of these 3 portals, and it's been adopted by the European Glaucoma Society. This can offer a free personal audit for individual surgeons, a large data set of international comparison. It can give individual companies with new devices data for regulatory purposes, and ultimately we're looking to use it for patient-reported outcomes across the spectrum. And this is a thing I've been involved in with my partner, who's Nathan Kerr in Australia. And we have 3,000 patients almost on it now, and it is being supported by a research grant from Allergan and we have a lot of interest from other countries. Ophthalmology Futures I've mentioned briefly. If any of you with any of these exciting technologies have anything that you want to share, please apply to present at our next forums, which will be virtual and will be free. There's no charge to present and no charge to attend. So a new direction. Well, there's a huge unmet need in glaucoma patients, and it's not addressed by the huge rush into Schlemm's canal. That's certainly part of the issue, but it's not the whole thing. Mixed innovation is stimulating research into the more complex area. And thank you very much for your attention. And Ike, thanks for staying on if you're still there.
Keith, thank you very much. I really like your idea of putting up a registry for glaucoma surgery. You know, we have some experience there in the cataract world with the ESCRS.
You're way ahead of us.
And there's also, you know, in the refractive world, but there's also a couple of learnings in terms of, you know, how accurate, how precise are those data. So what do you think? Should we not go way beyond and saying, you know, let's collect data, you know, for big data challenges like Ashwin is proposing, or does it really have to be on a registry level?
Well, you're absolutely right. The first challenge with data is actually getting doctors to put anything in anything. And if you've got an EMR already, then you're collecting data. But things like the IRIS registry take data from hundreds of EMRs, put them all together. For the individual surgeon, the EMR doesn't produce much of a tailored personal audit report. And for small companies who want data tracking, the EMR they want to get data from a lot of different centers, perhaps using different EMRs. And it struck me early on that while the UK could produce very good cataract surgery data, it's not going to really produce enough glaucoma surgery data to be at the same scale. Glaucoma surgery is just not common enough. So we had this idea to try, and we thought it's easier to internationalize it than and have it web-based, convenient, with a minimum data set, unlike a cumbersome EMR. And ultimately, we will download from EMRs and assimilate EMRs in the future, but at the minute, it's just surgeons.
Yeah. So do you think the pathway is, you know, in some countries, the cataract registry is actually the insurances force the clinicians to enter data to reimburse? You know, I think it's in Sweden, I think in Switzerland, you have to report on a regular basis your outcomes. Do you think that's a pathway we should go here, or to? That
was one of the stimuli for me starting this, because you know, our medical director came up to me and said, I want an audit of all your personal glaucoma surgery, your private glaucoma surgery. So we put together a web-based registry with minimal data entry. Part of the problems, as you know, with firstly, insurances will almost certainly drive this as well. And you could say me being driven by the NHS is the same sort of thing. Yep. But it will be useful, and I don't think glaucoma is anywhere near matching cataract in the sophistication of this. And this is one simple way to get much closer, and also to cover the whole spectrum of glaucoma surgery.
I think that might be a wonderful topic, and maybe you can explore this towards the direction of Horizon 2020 program. I know they're launching projects and programs to finance big data collection with, you know, even, you know, fewer indications and fewer prevalence. And it might be a pathway to, you know, collaborate on an industry, university, and an international level in Europe. So maybe that's a suggestion here.
Well, that would be interesting. Currently, our main, this has largely been funded by a research grant from Allergan, and you know, we made it absolutely free to the surgeons, but ultimately we need commercial drive to make it work, I think.
Right,
yeah, but
so, Chris?
Well, I was going to say, to that point, I think a lot of, you know, because there's so much activity in the startup segment with glaucoma, that could, and a lot of these companies don't know where to start, and they often start with retrospective data or equivalency, which in Europe, as we know with the regulatory changes, is going to make it more difficult to claim equivalency. So to me, something like this, giving access to the startup companies at an earlier stage would enable them to harness and collect better data, or generate better data than what's being done to date. Because from my perspective, what we see is often just disastrous retrospective data that can't be used.
Well, we've been doing this, and we've been working with one large company and one small company to actually data track for them for FDA approval at the moment. So I think that's going to be a useful way to drive the registry. But I think we're cheaper and simpler than what in terms of data tracking, or what many CROs might offer for companies.
Very fascinating. Yeah. I think thank you, Keith, for your insights here, and sharing with us how you see the futures moving towards glaucoma surgery. We're running a little bit late, so I'm going to close out this session and the meeting. First of all, I would like to thank all the speakers. Your insights on what's happening out there, your passion in the field, sharing with us the passion. Wonderful. Thank you so much. I really appreciate every single talk. The second thing is, I think for me, a big take-home learning today is data are mattering. And I think the way we are matters, and the data, how we're looking at data, how we're interpreting data, and how we're generating data is going to change moving forward in ophthalmology. It's going to be a big change, maybe also driven by the COVID times, but I think this is very exciting, very innovative field. And the last thing is I would like to share with you, if you are out there, if you have an idea, if you are involved in a new technology, please do not hesitate to contact us. We are planning to set up the next meeting. We're looking towards the end of September. Temporarily, we were looking for the 23rd of September. So if you have a topic, please reach out to us. If you're a clinician collaborating with technology, if you're involved in innovation, that you would like to share, it should be something that is not longer than 12 months in the market, or should be in preclinicals or clinical trials. It should be something new that you think will come, that you're passionate of, that you would like to share with colleagues and among the industry. Reach out to Chris, to me, or to Eileen. Thank you very much. Enjoy your evening, and thank you very much for joining. Thank you very much. Bye bye.
Thank you. Thank
Bye.
you. Bye bye.
Thank you, everyone.
Thank you so much.
Bye.
Bye bye.
Thank you, Eileen. Thank you, Michael. Thank you, Chris.
Thank you. Bye bye.